history of the pediatric intensive care unit at Hopkins and pediatric anesthesia at Hopkins is tied into the history of anesthesiology at Hopkins. They had just created a department and recruited someone to come in who was the chairman, and Dr. Gene Nagel, who was anxiously trying his very best to build a department, but was given only very limited resources to do it. He was very generous to me, however, and even though I had been recruited originally in the Department of Pediatrics to found the Pediatric Intensive Care Unit, he was very supportive of me, which turned out to be important. Unfortunately, at the end of the second year, Dr. Nagel had to leave, and they came to me to ask me to be chairman of the Department of Anesthesiology, which, to my surprise, even in retrospect, I had the courage to say no. Why did I say no? I said no because the resources were not sufficient in terms of space, money, research laboratories, other things that were important for the field. And it turns out that since they were critically dependent on anesthesiology, they decided to allow me to rename the field Anesthesiology and Critical Care Medicine, and provided a significant infusion of new resources. We then built the Pediatric Intensive Care Unit with resources that came largely from the Department of Anesthesia, allowing it to grow astronomically in this new Department of Anesthesiology and Critical Care Medicine. My goal was, based on the experience I had in other institutions, being a pediatric cardiologist, was to develop a field that was broad-based, based on solid science of disease and patient illness, that was also supportive of doing real research in the field and fulfilled the criteria of having fellowship training and of having boards in the field. We needed a field of research that was intrinsic to pediatric intensive care, and that we decided was in the field of neurologic injury. And in neurologic injury, there were two developments that resulted in the ability to make that field come alive for us. And that was my recruitment from the Department of Public Health of Dr. Richard Traceman, perhaps one of the preeminent cardiovascular neurologic-oriented physiologists, who was an expert in cerebral blood flow and metabolism. And we wrote together hundreds and hundreds of papers in this field, and he trained dozens and dozens of fellows in the laboratories. Our concern was that our people would not go to books of pediatric cardiology to look up the heart disease complaints of their patients, but they wouldn't go to a pediatric neurology book to be able to look at what was going on in the field of neurology, that we would have all of it, including infectious disease, inside our own textbook. And that textbook became the Bible in the field. It's in its 4th or 5th edition today, and is an 1,800-page textbook in its first edition, probably still reasonably far along in that regard. But if you want to find out anything that's going on in pediatric intensive care, then you can look it up in the field, and in fact, that became the basis for the training necessary to pass the boards in pediatric intensive care. There was one other development that should also be noted, which I'd like to highlight. Every other field had an international meeting of the specialists, and we formed the International Congress, the International Organization for Critical Care Medicine and Pediatrics, and that specialty meeting was held the first meeting was held in Baltimore, and we actually had to provide support to get representatives from then the Soviet Union, from some of the poor countries in Southeast Asia and in South America to come to the meeting, but we ended up with several hundred people coming to the first International Congress on Pediatric Intensive Care. So at that point we had done virtually everything in terms of having a pediatric intensive care unit, a training program, a long fellowship program, a research program, a textbook, and boards. And the thing that we needed next was to round out the pediatric anesthesia component and the treatment of pain in the patients. And in that regard, we were very fortunate in that we had recruited Dr. Myron Yaster, who came as an assistant professor and helped found the whole area of pediatric anesthesia related to pain treatment. And now we had both pediatric anesthesia and we had pediatric intensive care, and both of those grew symbiotically into an enormous enterprise in which, as I sit here today in the new and luxurious offices of the new Children's Center at Johns Hopkins, they have more people in the division of pediatric anesthesia and the division of pediatric intensive care than I had in the whole department of anesthesiology and critical care medicine when we started. I guess it must be now 25, 30 years ago.